different work streams. And this year we have concentrated our effort into 3 different work streams. The first one, and which this workshop belongs to, is the health data spaces and ecosystems. And this is the result of merging 2 work streams last year on European health data spaces and health data ecosystems. We have a new topic for this year, hybrid care, because we are experiencing and observing the effects of the COVID pandemic in terms of use of virtual care and how this virtual care will be combined with regular care in the future. So there is a lot of challenges around this new modality of hybrid care. And a third work stream is what we call Mind the Gap. There is this acceleration of digital transformation, but there are many elements that have to be tackled in order to close the gap between what is possible technically and technologically and what can happen in reality. So this is our work program from this year, and we encourage you to follow our workshops and webinars. Last year, in the 2 work streams in European health data spaces, we organized 5 different workshops, 3 for the European health data space and 2 for the building health data ecosystems. And you can have access to the result of these workshops that we have produced in the format of fact sheets and on the chat box on the bottom of the slide, and the slides will be available after the session on the website, and all the fact sheets for your reading. This year, as mentioned, we have this new work stream on health data ecosystems and spaces, and we have foreseen 3 topics. The first topic, and this year compared with last year, we want to go more into concrete examples of how data can be combined to produce value, and particularly in the domains of health service delivery. And the first will be around mobile health data and health service delivery. We plan to have one in June on data-driven hospitals and how hospitals are incorporating data from different sources to improve their value chain, and especially for the massive use of data for the development of clinical decision support systems. And in September, October will be another one on reference architectures in the health sector. At the end of the year, we plan to have the symposium as every year, where we will also feature these topics on health data spaces and ecosystems. The agenda for today is very rich. We have 2 presentations to keep note presentation. One from Guido Giunti from University of Oulu, from, let's say, the supply side. So we will have a journey from the idea to the integration of health services. And then we will have a second presentation from Yolanda Lupiañez from TIC Salud, from the demand side, how the health system is organizing to capture all this data and make good use of this. We'll have a short live poll, and then we will open the discussion with a distinguished panel of 5 experts that I will introduce later in the discussion. And finally, we'll have the conclusions of the session. So let's start, and we'll start with the first presentation from Guido. The idea today, as I said, is we want to explore these different paths to integrate patient-generated data, and in this case, through mobile health applications, and how they can be combined to improve clinical work and generate value, but also to discuss about the challenge from all domains, from legal, organizational, technical, human, that holds back sometimes the adoption of these innovations, and how they can overcome these barriers. So I will ask Guido to take the floor. He's a physician, he's a specialist in internal medicine. He's also a researcher in University of Oulu in mHealth. He's managing the section on serious game in the prestigious journal Medical Internet Research. And he's also an entrepreneur, so he can provide many views. And we asked Guido to give us this outsider-insider view of how an idea can become a reality and integrated into the healthcare system. So Guido, thank you very much for joining today, and please show your presentation.
Thank you everyone for coming, and thank you so much for having me here. As Tino was mentioning, my name is Guido. I'm a medical doctor, and I work at the University of Oulu in the very, very far north of Finland. Please, next slide. Basically, I want to tell you a little bit about what has been the journey so far in this case of more stamina, and one of the different challenges. And as Tino mentioned, I am a medical doctor. I'm a family medicine or internal medicine or primary care. And I was trained and basically practiced in Argentina. And then because of my tendencies to be involved in digital health and innovative technologies, I ended up having the opportunity to go and work in a company in the south of Spain. Tino, please. So what I meant was that I was so basically this meant that during most of my practice, this was as close to data management and electronic health records that I got, and this was a problem that I found very fascinating to see how we can make use of this information and how we can find meaning into this. And that's the type of thing that actually led me to be working in a company in Spain. So now, there we go. And when I was working in this company, I was working in this digital health company that was a small startup at the south of Spain. And I was involved in the process of, in the product development of different types of mobile applications. And after working over there, I ended up traveling all the way to the north. Next slide, thank you. So that means that I had to go from the sunny south of Spain to the cold north of Finland. But there was one thing that kept appearing in different places, and I would like to share a bit about what's the story or what's what I usually perceive as the typical journey that different types of mHealth applications have. So as you can imagine, usually what happens is that you have these different actors. So you start with the patients, and that's there's a need, and this need creates this idea. Now, what happens is that initially people start to think what would be a product. You automatically think, next slide, please. You automatically think that this idea is going to create a product, and then I'm going to go automatically and reach the patients. However, maybe we think that the scale of what we're doing will be bigger, and we need to include other developers or different types of actors. And when we start to work with the patients, we realize that for them, the first thing that they end up doing when they have this type of solutions is that they go to the healthcare professionals, and they are the ones who are starting to have this first barrier in that case, because we're starting to think about with them and the healthcare professionals, maybe they don't really understand what's the value, what are we doing here with this medical application. And if we manage to actually overcome this barrier, we then need to be thinking about how we can include or integrate this into a healthcare center or into a hospital service and so on. And that usually requires that we start involving research and start to create research. And then what happens is that in order for us to create this evidence, we need to start thinking about how can we make this into a way that actually influences the policy that creates a change in terms of the healthcare centers, so that they can actually change and adopt this. And very lastly, we start to think about how do we make it sustainable, how do we create some sort of a business in a way that it doesn't exist only as something that happens in the the process of just like creating grants and so on. And finally, we go to the final obstacle that we reach here, which is the fact that these people, these patients, are actually human beings who have families and friends, and who themselves are actually also potential users and potential barriers or facilitators of this adoption of these technologies. Next slide, please. So what I'm going to do now is I'm going to tell you a bit about how More Stamina, this project for multiple sclerosis, actually happened, and what's exactly the journey that we went through. So in very few words, the general idea about More Stamina is that this is a digital health solution, and it's supposed to be to help them manage their fatigue. So what we have here is that as the different patients use the app, it starts to track their day and provides them general personalized recommendations. And the information that we gather, we actually use it to discover hidden characteristics of the condition in a way that we can enforce them. Now, what's particularly interesting about this project has been that we have actually been following this very user-centered design all the way. And we have actually done something that I like to call evidence-driven, and you're probably going to see why very soon. But at the current stage that we are in, we're basically part of a project that's been funded by Business Finland, in which we are trying to explore different things to how do we actually get this to become a sustainable business model. So one of the first things that we need to consider here is that with my background as a family doctor, one of the things that I kept having in mind when I started to look at this problem is that, as I said, patients are people, and people have their own needs, they have their own agenda, and there's this concept in family medicine that talks about the tension of agendas, which is basically that me as a healthcare professional, I want to give treatment to my patients, I want to take care of their needs, but at the same time, their patients have their own, you exited the slide, there we go, thank you. The patients have their own agenda, their own needs. They want to live their lives. They want to do whatever is right. So when we started working on this, instead of starting thinking about what's an idea, what's the product, we actually went to the patients first, because that was the natural thing for us when we started working them. So first, next slide. So as we were working with the patients, we knew that we had to base our solution in something that has to do with the data, with the data and the value that they need. Because basically we want to have these patients do something that empowers them and takes care of their condition, but at the same time, this has to be meaningful and impactful for the healthcare providers who actually need and rely on the evidence. And this is something that has to be supported by the people who are surrounding these patients. So when we were working on this, we basically tried to understand what were the needs of people with multiple sclerosis. So what we started doing was we put together patients and healthcare professionals, and we did a series of focus groups to try to understand what actually are their needs, what do they want. So next slide, please. So we were basically trying to understand what do the patients want, and also what do the doctors want, or healthcare professionals, nurses, and so on. And especially what were the topics that were the most pressing? What was the expectations that they would have from a digital health solution? So next slide, please. So here we were starting to think about a product, but perhaps not in the way that you expect. So instead of going, please next slide. So instead of thinking we need to come up with a product, we started to think, okay, there's probably hundreds of thousands of applications. There's things that are already there. Maybe there is something that actually addresses the needs of these, and this is a barrier in the sense of the information needs, or in the fact of the health literacy or e-health literacy that these people have. So basically, maybe this is a problem that healthcare professionals didn't know that this app exists, or maybe there was a problem in the sense that the family members or the patients themselves didn't know that this type of solution existed for them. So what we did then is we started to explore what were the different applications that were available. Next slide, please. And what we did is basically a systematic review of all the currently available applications that were there, looking for things that had to do with multiple sclerosis. And after looking for thousands of thousands, we found that there was basically only 25 apps, and most of them were just aimed for doctors and not in terms of managing the condition, but much more in terms of the needs. So, the information needs. So next slide. So that sort of led us to think of what could we do about this. So we could be doing something in terms of an idea, what's something that we can create. But again, we didn't think of this, we didn't approach this in the way that you expect. We actually had this series of co-creation workshops in which we had nurses, physicians, engineers, designers, patient representatives, and we went to different conferences and events to try to gather the thoughts and perspectives from each of these different stakeholders and actually try to come up with different concepts or design concepts of what could these potential solutions be. So once that we have this kind of ideas, only then we started to think about, okay, how can we develop this? How can we actually create a solution? And in this way, what we're doing is, because we have already all of these different actors, all of these different players in mind when we were thinking of this, the way that we approached it was completely following, because we knew that for the patients, it was important that it gave value. We knew that for the healthcare professionals, it had to be evidence-based, it had to have foundations, and we knew that this is something that required the production of further evidence and further literature for the researchers so that they can act on this. So when we were coming up with this solution and we were designing the concept further, we were actually having this ad hoc process in which we were trying to test the different behavioral change models and how can they fit with the literature and how can they fit with the actual needs of the patients and what is limited by the technology and what's something that the technology can actually allow us to. Next slide, please. So what's interesting about this is that this kind of approach that we took, in which we were always trying to integrate and have the stakeholders here, had a very interesting set of responses. So we, of course, had lots of people. Fortunately, we had lots of researchers and lots of healthcare professionals approach us, asking us, hey, can we be part of this? But most importantly, we were actually getting hits, and we were being contacted by people on social media asking us to try the app. And what was interesting is that at this point, the application didn't really exist. This was just a concept that was designed and that appeared in a scientific literature. So that gives you an idea about how much value we were talking here. We're talking about something that has, at each step, we were validating the value proposition, so to speak, and we were actually validating what is something that the market needs and what is something that could be integrated there. So when we're starting to look at how can we make this scale, or how can we think of this in terms of something that can be integrated with the healthcare centers, that basically proposed how do we figure out the health outcomes. So in that sense, we're thinking, okay, we know that we need to test this with patients. We are fortunate that this is something that we're doing with partners in different environments, with partners in Spain, Switzerland, Argentina, and Finland. And the idea is that we're trying to validate, okay, how good, how well patients and the concept really works now that we have this prototype that works and can actually do something. So when I mentioned that we were doing this evidence-driven base, is that because every single chain of the things that we're doing here were actually resulting in a publication, and it was actually building up on each other in a way that is interlinked, and is creating this sort of evidence trail, but it's actually the way that we are building it. Because, for example, we're not right now, the reason that we're doing an app is not because I wanted to do an app or someone in my team wanted to do an app. It's basically where each of the steps we took led us. And that's where we are at this moment. So, for example, next slide. When you need to understand of what's the actual context in which we're doing this now in Finland, which is a highly developed, highly digitalized context. We're talking about a place where there's 100% electronic health records, and there's, of course, also electronic prescriptions, and there are already infrastructures that are implemented and in place. So whatever our solution is has to be in sync with this. It has to be interoperable. It has to be something that functions with this environment, because that is the expectation. Next slide, please. And right now, because we are based in Oulu, we're based in the north of Finland, and we're talking about something that is part of this Oulu health ecosystem, which is composed of this arrangement of stakeholders who are from academia, public sector, private institutions. We have different types of players who are all intimately connected and who try to find ways to cooperate in this sense and develop the ideas further. So for example, next slide. So for example, when we're trying to think of how can we do this, how can we implement this in a way that can become a health service, how can we find this chain of different actors, this chain of different stakeholders, this idea of different bridges. There are different types of data that needs to be exchanged and that are collected from our application, from our solution in mind. So for example, next slide. So for example, we are generating, thank you. So for example, we're generating data that the patients are using by using the application. So that we gather all of this information. And one of the main challenges that you have here is that we have this vast amounts of information that is gathered from them, but we need to transform that into something that is meaningful for the healthcare professionals. Because if we have this embedded into the electronic health records, and I have the amount of steps that the person has actually walked, that's perhaps not interesting to me at all, and that's something that is going to overwhelm me as a healthcare professional. In the same sense, we're talking about this information that you can pull from the electronic health records to sort of feed the machine learning algorithms that we have in our application. But there has to be a specific way and a specific need to which we're asking this. You cannot just be mining data, especially sensitive data like health information, just to train your algorithm. So we're talking about how these different ideas and these different concepts are actually touching points of the data ownership and the patient perspective. So all of these things, next slide, and of course the information for the policymakers. Now, all of these things, the way in which we're approaching this is that we're approaching this in a participatory design manner in which we are iteratively designing and developing the use cases. And this is one of the things that we're continuing working and improving right now as part of this business Finland funding, in which we try to understand how can we make this into something that can easily, or as easily as possible, be integrated into the healthcare system so that it can be implemented as an actual care pathway. And this is something that requires a lot of effort in the actual understanding and the actual gathering of meaning for all of these things. Next slide. Because one of the things that are the worst that can happen here is that we have here something that is on the screen. We are seeing now that there's this innovative idea that is isolated, that is outside of the box in the negative way, in the sense that this is excluded from the actual functioning. And that's something that we need to be working towards so that we can improve and that we can actually create these interoperability bridges and this way in which we can actually accomplish a truly data ecosystem that connects these different players. Next slide. Because we always have been thinking, and we've been saying for a long time, that digital health is the future, that medical informatics and so on, that all of these things are the future. But the main thing that I want to say is that this is actually the present. Like, one of the things that COVID-19 has sped up is the adoption of these technologies, So we need to start thinking exactly how do we want to be living right now and act on that. So thank you very much.
Thank you very much, Guido, for your presentation. I don't know if there are any questions in the chat that can be addressed now, or we move to the next presentation.
Are you, based on your experience, Guido, are you really considering that the principle of participatory design is the key for integrating mHealth and the health service and the health service value chain?
Yes, I would not say in the sense that it is the key, but I would say that it's something that, as a philosophy, as an approach to integration, I think is very valuable. Because basically we are very much used to this idea of a dominant stakeholder or someone that actually rules or guides the process. And with participatory design approaches, we're talking about something that is perhaps a bit more proportional and perhaps more evenly distributed. I am, of course, biased because I am working within the Nordic perspective, and that's something that's kind of like the birthplace of the participatory design movement. But yes.
So if there's no more questions, we can move to the second presentation, and we are now going into the box, and which are the views from the box to the outside world of mHealth data. And for this reason, we have invited Yolanda Lupiañez from Salud Social. Yolanda, she's engineering in informatics. She's the director of digital transformation in the Fundación Salud, and she will introduce the topic of integrating data from mobile devices into the healthcare process from the demand side. So, Yolanda, thank you very much for joining, and it's for yours.
Thank you, Dino. Well, good afternoon, everyone. First of all, I would like to thank Ethel to give us the opportunity to share with you our experience, and I will also like to thank all the attendees for your presence today. As referred by Dino, today I want to talk about our experience integrating data from mobile devices, that means data from medical devices, wearable and apps, into the healthcare processes in Catalonia. Let's start by taking an overview of Catalan healthcare model. It's a decentralized multi-provider model integrated in a single public network, enhances the autonomous management of each provider, free to select their information systems. In this context, interoperability among the different ICT systems is a must. The Catalan Ministry of Health is in charge of 7.5 million people healthcare assistants. Our life expectancy is around 83 years old, and 18% of the population is over 65 years. I'm representing Salud Social. Salud Social is a public agency within the Ministry of Health, and whose aim is to facilitate the digital transformation of the health and social care models through technology. Now, in 2015, Catalan government approved the first Catalan mHealth plan and nominated Salud Social as commission by execute this strategy. This plan clearly identifies as a key goal to achieve the integration of the mobile data into healthcare processes. And to achieve this goal, the plan defines several initiatives to be carried on. First of all is to design new technical guidelines on developing secure, usable, interoperable apps, setting up an accreditation model to ensure quality of these apps, developing a new corporate mHealth solutions, and starting up a new showroom to present, to promote all these certified apps, and putting into service an innovation observatory. Now we are focused on these two initiatives. Next, please. But how do we prioritize processes to be transformed? The priorities are set by a group of multidisciplinary group of professionals from the Ministry of Health, and this group takes into consideration several aspects. What are major health issues, of course, and also clinical aspects like the percentage of the population affected, the amount of effort required to transform the process, also the associated costs, and impact of this transformation in terms of the benefits to the professional and to the citizens. Next, as a result of this prioritization, in 2021, we are working on 3 processes: monitoring diabetic patients, monitoring bipolar disorder patients, and pain monitoring after drug infiltrations. But today we are focusing on diabetes, and why? Because it's planned to do a new public procurement process by mid of 2021 in order to buy all the required materials for monitoring patients with diabetes. This procurement will be executed by several public administrations, but all the requirements regarding data integration and sharing are common, are the same. This procurement means 36 different types of medical devices, such as glucometers, insulin bombs, continuous monitoring sensors, and apps, because the major part of the providers have apps to manage all these medical devices. 12 providers from 5 different countries, and involves 150,000 patients. And much further, this procurement process is identified as a great opportunity to set up a new relationship model with the industry and lay the foundations for share data and integrate this data into our processes. And finally, this project will drive a big change in the way we use and share information, both in our processes and across the system. Next. In order to achieve this goal, we have faced several challenges. First is ensuring apps quality. Second is defining and agreeing a set of relevant data. Building a new technological architecture and platform, creating an interoperability framework, and the last one, helping industry to be prepared. Let's see briefly each of them, because I think it's important. 5 years ago, we developed an accreditation model to ensure apps quality. This mainly consists in reviewing 120 evaluation criteria regarding design and usability, content and functionality, privacy and security, and of course technological requirements. And all these tasks are performed by an experts committee integrating academics, medical societies, and of course engineers, and with the objective to certify the apps, the quality of the apps. Next. The second one is defining and agreeing a set of relevant data, in our case by executing a 4 steps methodology. The first step is, of course, to establish a multidisciplinary working group with professionals from all the specialized care, primary care, pediatricians, and so on, to defining processes, change requests. In my opinion, in our experience, this step is the most relevant because you have here the possibility to change the goal of the processes and add value to the processes. For example, by setting alarms when the information is not correct or is out range, for example. You must identify representative clinical variables and agree them, and it's a tough question, and transforming it on a standard clinical terminology, and in our case, by using SNOMED-CD. Talking about technology, we have built a new system called mConnecta. mConnecta is a new platform designed to collect and integrate all information from apps, wearable, and medical devices, and make data available for all the systems in several levels of assistance: primary care, social health care, mental care, and specialized care. And of course, to put it available to our corporate systems, personal health record and electronic health record. So mConnecta also provides a new digital patient and professional digital journey. Next, please. Because mobility elements are prescribed to patients by the professionals, patients can access to upload information, and this information is in real-time tracking, and relevant data generated is integrated to the health patient's record. And to make it possible, it's mandatory to create a new interoperability framework. In our case, by heavy use of international standards like FHIR to do all the integration between different data origins like mobile apps, wearables, medical devices, and other web platforms, and to publish all the data to different EHR systems and corporate systems, and SNOMED-CD, as I said before, to codify and use standard terminology services. And finally, and I think it's one of the key aspects, helping industry to be prepared by providing them information, tools, and support in two ways, mainly in how to develop and construct all the interoperability message through a FHIR system, and how to analyze the GDPR impact on privacy and ICT solutions, because for us, privacy is a very, very important thing, and it's mandatory to have solutions with privacy by design. And finally, to sum up, next, let me remind our challenges and the solutions we put in practice to overcome them. First is provisioning trusted tabs via our accreditation model, identifying and standardizing relevant data and sharing data between or across all the systems, mainly with the co-creation with the professionals and industry, and building this interoperability platform, and collecting and integrating data from mHealth and sharing relevant data across the processes through our mConnecta technological platform. and at least dealing with changes, basically with a strong commitment with professionals and industry, and doing training and support. And this is all from my side. Thank you for your attention.
Thank you very much, Yolanda, for your presentation. I think there are some questions in the chat that are for clarification. So I can ask maybe Diane to pose the question.
Yolanda, I'm going to pose a question to you, but then I will pose a kind of question that's been asked to both you and to Guido. So I'll ask that second. The first one to you directly is a very simple question relating to the last slide about privacy impact assessments. And it's whether in Catalonia you have services or advisory groups that can help you do that. I know it's quite a complex process to do so.
Yes, we have a specific group within the SCLEROSIS Foundation, and in my presentation you have several links to our tools, and these are open tools, and is a specific methodology to show you the different steps to accomplish with this regulation. It's very useful and practical, and I insist it's open, and we have also we are willing to help anybody to follow them.
Great. For example, health technology assessment as well. This is both for you, and then I'll go back to Guido. Do you undertake that process with help and assistance as well? And how long have you been doing health technology assessments?
I think that early health technology assessment is something that is very, very valuable. And in our case, this is something that we are currently exploring as a way to inform the process of the product development. So for example, right now, we are using different frameworks. So here in Finland, there's this DGHTA framework developed here, and we're trying to see if this is something that can help us be better at complying with the actual expectations for interoperability and integration. I think that if we would have a bit more, if as I was saying in the comment, if those of us in the field, we were more aware of the existence of this type of frameworks or this type of guidelines early on, it could very much facilitate the integration of these solutions, because usually you tend to see a lot of people acting as lone wolves or individual innovators, and that's kind of how we this ecosystem approach is extremely valid, I think.
So, Yolanda, do you have health technology assessment in place, and how long has the process been going on for, and what's worked well, what hasn't?
We are working with DACUAS, is the Catalan agency in charge to do this kind of assessments, and we are working together to fit the process, because we don't have a specific methodology put in practice, but we are also following the NHS methodology, but we don't have at that time results. We are working on it. And answering Marcos, this process is not already launched, because we are working with the providers to be ready for the new purchase process. And the new procurement process will be in July.
Right. So yes, everybody, those questions were posed by Marcus Kalliola of Finland. So thank you to Marcus, and thanks to our two speakers for their replies. Quick question to both of you. Guido, there's been a lot of dialogue in the chat, in particular with Belen. But the question to both of you, maybe Guido first, Yolanda second, would be, is there anything that you would really have done differently at this stage of the initiatives that you're at? Is there anything that either of you would have radically done differently with the learnings that you have from the experience? Guido, I think you've had some time to think about that, whereas maybe Yolanda has not. Guido.
Sure. So one of the things that I was mentioning over there in the comments has to do exactly with that. I think that if we had been much more involved, or we would have involved more the policy aspect, or this kind of like higher level approach, that would have been very helpful, because as I was saying earlier, when you start having these ideas, or you start trying to create these clinical innovations, it's very difficult to actually understand the larger picture. So that's something that from the beginning we were not exactly clear. Of course, because of my career, I have been working in different places, so the type of support was different when I was working in Argentina than when I was working in Spain, than now that I'm working here in Finland. But one of the things that was very, very present everywhere is that the efforts for making us aware that these tools exist, for example, the ones that Yolanda was mentioning, become key as the innovator. It becomes key as someone who's trying to develop. It has to be like a evangelization campaign, I would say.
And actually, what struck me is that in the two examples we had, actually, both start with an analysis of what is available in the market, and they have a use case, and they developed quite a journey, I would say. In the case of Guido, you see he published an article for each of the single steps of his reflection. I say, well, you know, I surveyed I don't know how many thousands of apps on the market, and I ended up with 25 which were more or less focused on my topic. And then at the end of the day, I discovered that actually it was not answering my question. But my needs, so he decided to do all the process. In the case of Yolanda, we start from a different perspective. Once here again, they decided on what they wanted to work. They surveyed the market, and then they started, and Yolanda, you will tell us if I'm wrong, a long journey also with the 12 providers. And still the tender is still to come. It's still to come. So it means that others might come. But for months, they are now working closely on how to build a solution which will really deliver. Deliver something for the patient, for the people who care for them, and for society. That's basically the key aspect of it, because Yolanda, you mentioned it, but clearly you will keep the data provided by the apps in a central server in order to further work on it and to create new knowledge altogether. So, and in the case of Guido, also clearly they set up an ecosystem which goes beyond borders. And I think what you said, Guido, at the very beginning was very interesting. It was actually with your picture and the journey from the patient to the healthcare provider, to the hospital, to the possibly to the researcher, and maybe one day to the policymaker. We see how many doors are today closed, basically. And those doors, most of the time, do not have the same keys even. So that's what we are speaking about today, is building a common house and a common workflow, integrating the societal value. And clearly, what I see now is that if this is not done from the very beginning, actually, even from a purely business point of view, there is a lot of chance that the solution will not have big future. But without any delay, maybe I would like to ask first And ladies first, I'm sorry to Heather, who is from ORCA, and with the associate director working on partnerships within ORCA, and ORCA is based in the United Kingdom. And ORCA, I think, is extremely aware of the need to have an integrated approach, not only as an isolated app dealing with a problem, but the need to integrate this app in a wider ecosystem. So ORCA, what has ORCA, for example, what is your experience in there? And what has been your main work orientation to try to improve that?
Yeah, thank you very much. And actually, just before I start, I might just give a quick overview of what ORCA is for those colleagues who may not have come across our innovation. So ORCA stands for the Organisation for the Review of Care and Health Apps. And I think it's important just to talk very briefly about our mission in the world, and it relates very much to some of the challenges, or answers some of the challenges that we've heard about today from our two speakers, and that is, how do you get high quality, safe digital health solutions to the people at the right time? And that means patients and organisations. And as we've heard this morning, there are many barriers in the way of how to do it. But I think the biggest barrier that we've certainly seen in our experience is that of trust. How do you find a digital health solution that you can trust, that is safe and that meets the requirements that the system and the patient require? A few facts here. There are well over 370,000 digital health and wellbeing apps available on the various different app stores, but only, in our experience, 20% of them meet the quality threshold that you would expect to see as either a healthcare professional or from a patient. And this, of course, means that you have a much higher chance of finding an unsafe product than you would of finding a safe product. So it's really interesting hearing how our two speakers this morning have set about sort of reviewing the, I think Guido said 125,000 different apps were reviewed to find the 25 that were okay for multiple sclerosis. So we've made our mission to really help both innovators and industry make sure that good quality apps that meet the addressable need of the market are developed, and we support our innovators in this community. But really importantly, we support health and care systems around the UK and the world to define how to accredit and how to build safe libraries. And now we've actually built the world's largest health app library that's filled with the best and highest quality reviewed solutions. We also build bespoke libraries for both in the UK, the National Health Service, but also around the world as well. Our health professionals, they use our libraries to as effectively their digital health formulary. We train them in how to do this, and also support organisations to prescribe the best solutions to their problems. So I guess we've responded to what we see as a real kind of market and innovator need to help review, accredit and continuously quality assure the very rapid evolution and development of health apps in the marketplace. And it's such an important part of the transformation of the digital system, the digital health ecosystem. So that's really what ORCA does, and we've just started to do some sort of collaboration work with colleagues on this call now to see how we can sort of share our mission and vision more widely.
Can you just maybe react on the co-creation process and the capacity for that to free data, so that actually they can benefit all the value chain, basically? How do you assess that? How do you assess that?
Yeah, no, it's a very good question. I've just filled in the online voting score, and I've given 5 and 5 for the two questions. And co-creation is a real challenge. Now, certainly in the UK, what we're seeing is innovators now are coming to professional organisations that will help them understand how best to link academia with patient interest groups and industry together with health and care professionals to create a common a common purpose and a common shared goal. But I say that we're just still at the beginning of this way of co-creation and co-production. And so many of the apps that we review don't meet the threshold for safety, security, and patient minimum patient standards because they have not included the all-important patient user focus at the beginning.
So would you say here that, for example, you can ease the job of Guido and Yolanda by doing the first part of their job, so getting rid of all the things, but they still need today to do all the rest of the job, right?
Absolutely, and I think there is a huge amount of duplication of effort in the marketplace. And wouldn't it be great? What if we could? You give Orca your requirements. You say we want to market test and benchmark for this particular cohort of users or a particular product or clinical group. And we can guarantee and assure that we've taken all the best of the ISO standards, the clinical minimum requirements, the DTAC standards in the UK, and provide you with a quality assured, constantly reviewed list of products that meet the thresholds that national and international governments dictate are required.
Thank you very much, Ethan. I would now like to turn to Belen, my second distinguished woman in the panel today, together with Javier. Sorry, you both of you from the Andalusian Health Ministry, and you are very active in the mHealth Hub project today, and you're coordinating it. And I would like your opinion on what Guido said, basically, that in the chat a bit earlier, and saying that maybe one thing you would have done maybe a bit differently is to try to have policymakers involved more closely also in the value chain, because we have seen that Guido had involved already many people, but maybe those ones were not closely associated because too far from the basic requirements, or the requirements from the people who would actually use those data. So what would be your view to this, and what is your impression from the policymaker perspective?
Thank you for the question, Luc. In our view, I think, of course, the policy layer is critical because you can impulse one concrete solution and it's no problem to implement at a large scale. But if you want a general landscape of mHealth adoption, you need policymakers fully involved and establish full governance. What I mean, technicalities are complex, and all the processes that we have heard today are very difficult to put in place. But from our experience, what is really, really complicated is to set up a governance model to govern all these different processes that involves, as Guido has shown, so many stakeholders. And that must come from policymakers. And from our experience, that's really, really complicated. You have to put in place a very solid strategy, and you have to wait probably many years till this comes to effect and it gets deployed. That's our humble experience also in Andalusia, which is quite similar. And we started from 2012, and we cannot see yet the light, the full light at least. And from our experience in the mHealth Hub, it's always the same. You have to get to the upper layers of policymakers, and then you have to go from top to the bottom if you want a full uptake of mHealth. Otherwise, I agree with Guido that a bottom-top approach is probably much more efficient, but it's very hard to get it full deployed. That's my reflection.
Yeah, maybe a supplementary question. As you now have quite a global vision of what's happening in Europe around mHealth, thanks to the mHealth project. What do you think is the current situation? Do you think that there is now a global awareness of the possible richness of those data, and what needs to be done in order to facilitate that? With this mix of, as you just mentioned it, of a bottom-up and with indeed a top-down approach in order to make sure that it also benefits the wider community. So do you think that a Catalan example, for example, is a small island in Europe, or do you see more and more people now or governments working on that?
I would say also that one element important is also the own beliefs and the own digital health literacy on the policymakers and the people in these areas, because maybe it's not needed like big enthusiastic, but at least for them to give the chance or to give the opportunity to this innovative way of delivering care. But and probably they work in most of the countries and regions in the short term, looking at elections and all these things. So it is a bit difficult to plan a long-term strategy.
Thank you, Belen. Maybe I would like now to turn to Eric Arsant, who is a researcher in the Norwegian Center for e-Health Research. And Eric, you have a tremendous experience already because you've been working on this subject since, if I'm not wrong, since almost 2 decades now. So it's a long time, and especially you worked on diabetes also, so you're pretty well connected to what Yolanda is trying to achieve. And this interoperability is not an easy thing to implement. We've seen that. Yolanda needs to work closely with the 12 suppliers and so on. But with all the background you have now today, how do you see things evolving since those many years? Do you think there is a consciousness now from the developers that they can't just work alone, and they really need to be part of a much wider ecosystem in order to succeed?
But you know, the industry is still in the lead when it comes to selling the product into the hospitals. And to take one extreme example, or perhaps the most advanced example here, is the most advanced users of mHealth, I would say, is people with type 1 diabetes who has a closed loop insulin pump. This pump has artificial intelligence. It listens to the glucose sensor, who measures every 5 minutes, and this is calculated. And in Norway, this data is actually transferred every night from the patient's bedside onto the Medtronic site in Europe. They have kind of found out a way of solving the GDPR issue here, but that can of course be questioned. So I think cybersecurity and security will be a huge in the coming. This is just the start example of how patient data is transferred to a commercial actor, who is of course keeping that for themselves, using it to be competitive among all other company who tries to make the best and make big money. So I don't know how to conclude here, but there's still a lot to achieve from the hospital side, from the governmental side. That they need to understand how this functions. So this has just started. Now it's the patient, the very skilled patients, who are able to do what I said, and namely transfer the data automatically into the hospital or to a place where the hospital can assess the data. Yeah, so we are in the very infancy of integrating mHealth data into clinical care, I would say. Even in Norway, who's a very rich country, we have all this technology, but we are so dependent on the industry, and we don't have the the rules or routines yet at all, I would say.
Thank you very much, Eric. I would then would like to ask to Marcus Kallioka from Sitra in Finland, that most of you know already, as is a regular distinguished guest in later webinars. But Sitra has been very much working on ecosystems, and it's also now leading the new joint action on health data space. So trying to consider actually those two sides, basically the ecosystem which needs to be built rather from a bottom-up approach, while having the vision and having the policy support to know what needs to be done by whom. But Marcus, maybe can you react on two things that I think which look important? Is to say, here we see that creating an ecosystem most of the time with money, public money at the beginning, when you create the innovation, when you want to involve so many actors, and especially if you want to involve many countries and so on, that's usually the way it starts. But and you raised a question to Yolanda in the chat, but what kind of business model can be established in your mind in order to sustain this wider ecosystem in the long run? And that's the second part of the question, is that actually that ideally should be not a one-shot partnership. That should be a longer partnership in order to gain value. Even when an app has been developed and is being used, ideally, it should only be the beginning of a journey. So what are your main thinking when you consider this point?
I think, look, very good questions, but I don't know if I don't have answers to those those questions. It's a very difficult field and sector, and in the data joint action, we are actually solving an easier problem than what we are talking about here today. So we are talking about the secondaries of health data European wide, and even though that seems complex, what we are talking about here today is the care process, is the apps that basically any one of us can start a company and create an application and push it to the app store for healthcare purposes. The challenge that Yolanda has described here with the M-Connector and all that, and also what Orca has been doing for years, trying to review these applications. And it is a jungle out there with so many applications, and it's completely different problem than what we are used to face in a healthcare, where we have very defined medicines coming to the markets that have very traditional processes, and even medical devices have notified bodies certifying the devices. And in the health app, it's a totally different landscape. However, I think the problem is so wide that it's very difficult to think that these kind of regional solutions, even though they are of course necessary once we don't have anything more, it's hard to see that they could scale insufficiently, and thus it's very difficult also for these innovative companies, such as we heard in the beginning from the Stamina app. How do you scale something like that in European wide? And even if I really much like the M-Connector, the solution that you have created and the answers that the solutions that you have started to solve, it's exactly what you should do, then consider that you are thinking there, what is the relevant data that you need to store in Catalan? Now, if all the regions in Europe are thinking what is relevant data for us, and then the innovator would need to implement 28 or even like 200 different regions, their different requirements for what is relevant data for our region, then it becomes very difficult to bring innovations in Europe in this mHealth field. So I think this data integration and what Eric said about the mHealth data, the data integration, the clinical care, it is one of the crucial problems to solve. Now, it's a very timely discussion, because actually in Citra, we have just launched a public, not public, but a tender process, and we have just selected the winner of that tender, and we are focusing on this problem on the digital therapeutics and looking into 5 European countries that has the most advanced settings for getting those apps in, or mHealth integrated into the clinical care. So exactly this, we are looking at the data, we are looking at the reimbursement processes and all that, and probably we'll choose after this seminar of Catalonia as one of the candidates, because we really want to understand how you're doing this. But we don't have a clear processes in Finland for this, and each municipality basically decide which kind of applications they procure for their patients, and what kind of what they use and what they don't use. For example, this diabetes insulation pumps. Some municipalities buy them for the patients, but not all do that, and some are using the more traditional ways of providing the insulin and checking the blood levels and so on. So it's a very difficult market in Finland. It's a very difficult market in Europe, and I think we need some European solutions, but I don't know if they are in sight. So very good discussion, and I very much favor of having more of these, because the problematics is very gigantic, I think, at the moment.
Thank you very much, Marcus. Maybe I will now just turn to my colleagues just to see if there is any questions in the chat for the audience. So Mark and Diane.
Hi, hello, Luke. I spotted 2, and it's related to business modeling. So in particular, in terms of mHealth apps, at what kind of stage in the process do you think that business modeling should actually start?
I could also say something regarding that. I don't know if the business model is the right word, but for the pricing of these solutions, Germany has this DIGA model where they have the digital therapeutics approval process, and they are collecting evidence for the use of the application. It is the innovator, so the company who brings the product into market, who prices the use, and then they have 6 months time to create the evidence, and after if they are approved to be reimbursed in Germany, then they have a negotiation with the board with the public authorities of what is the final pricing for the application. So it is sort of like a mixture of whether it's the company first pricing, but then it's defined later on. But yeah.
Marcus, that's a really good comparator to what happens in the UK. Let me tell you what happens here. It's a bit of a bun fight, as we say. There isn't really any structure of setting pricing and business modelling for innovation. Now, the NHS has come up with an organisational solution called the Academic Health Science Networks, and they bridge between industry, the health and care sector, and academia, and they're in place to help navigate and guide innovators that are developing apps in response to market need to develop a business model. But how you get that real world evidence and how you then develop the full economic case, which is so required in order to access sustainable funding that's not just derived from an innovation pot, is a real challenge. And what we're seeing now in the UK, we're seeing specialist companies, businesses cropping up that are very skilled in guiding and navigating an innovator to develop that business model, develop that business case, so that the argument, once they have a good ORCA review, of course, the argument to a health and care provider looking to innovate and adopt digital health into their pathways is easier. But even with a good economic case, even with a good business model, and with a highly scoring app score on the ORCA library, it does not guarantee. And although we are called the National Health Service in the UK, actually there's nothing national about our National Health Service. You have to take, as an innovator, your product and sell it repeatedly to your neighbours 157 times. So I would love to see a more systematic way of modelling the benefits of health and care apps. But I think certainly from a UK perspective, we are some way away from that happening. I saw Diane nodding her head. I don't know whether you agree with me there.
Yeah, yes and no. You may have spotted that there's a comment, Heather, from our northern neighbours in Scotland. So Donna Henderson is just very kindly pointing out that, in fact, the UK consists of 4 home countries, and the process that perhaps you're describing is rather, or is somewhat different in England than it perhaps is in Scotland, and maybe likewise Northern Ireland and Wales.
Yeah.
And in fact, Luke, there's a comment also from Zdeněk Guta, who's from the Czech Republic, who's actually saying, yeah, the discussion today is about countries that have already started and are well en route, but there are actually countries that haven't even started this discussion yet. I don't know whether you want to take that one up before we come back to a question that might be good for the panelists about statistics and numbers and what's happening where.
Yeah, thank you, Diane. But in the case of the Czech Republic, it's a good example because that's a country that the mHealth Hub is intending to support. So one of the 2 countries to start their journey, the mHealth Hub. But so yeah, indeed, we need to consider that. And that's, I think, Javier and Belen, you will not contradict me, that's something we very much have in mind in trying to imagine the key services that tomorrow should be available to support policymakers around Europe. But I see the time is running, so we are now about to close. I would just to close with one thing before giving back the floor to Tino for the final messages. But one thing which struck me very much in the preparation of this webinar and the discussion I had with Guido and with Yolanda is that, Yolanda, I quote you and say, I don't really understand why those people invest so much time and they don't even know if they're gonna get any money of it. Because I don't see how they're gonna make money out of all that story. I mean, they probably won't. And my understanding here is that it's, if they do so that's because they begin to understand that the ecosystem which needs to be created needs to change. And that's a learning curve. That's a unique opportunity they have to learn with you. They learn to learn how to connect in a system and how to be able to contribute socially also altogether. And they, I think, have understood now that if society is not part of the business model, you won't succeed in the future. So that would be my closing message from my side. But Tino, I give you back the floor now for, I see that Sabato, Diane, you said had 2 other questions, sorry. Maybe I don't want to close if it's not answered. Diane, I give you back the floor, just 1 second then.
I was just wondering, may I maybe put Heather on the spot with regard to those kind of questions? It's really about the numbers of apps or any other specialist. It's really about the statistics and the numbers of any apps being used, anybody who drops out, what the degree of compliance is, and given that the medical device regulation is being revised shortly, how many of those things are actually certified medical devices?
Yeah, that's a really good question. And so the process of review and accreditation that we take all of our apps through, that we have 2 types of entry point. So one, we proactively search for any new app that crops up on our radar. We're constantly scanning the iOS and Google Play stores. And actually, we do something called an ORCA baseline review, which doesn't cost anything. It's free. It's part of the general service that we offer. And only about 20% of those apps that we review make it onto any of our libraries. So 20%. And interestingly, we've just reduced our eligibility criteria if you don't score a minimum of 65%, or it might even be 70% now, then we just cut you from our libraries. We also offer, of course, the feedback to the innovator on where they've fallen short of our review criteria, and we offer to support the innovator to perhaps how to tighten up their security, tighten up their patient involvement, tighten up their evidence. So yes, so only 20% make it. Now, in the UK, sorry, in England, I should say, apologies for our northern colleagues, we are introducing a new digital standard called DTAC, and it's an enhancement on the entry level for digital standards to become an absolute minimum level to be commissioned by a health and social care organisation. We've just started doing this. Fortunately, 70% of the ORCA baseline review covers the requirements in the DTAC. So actually, for those organisations that have been reviewed by ORCA, they only have to have an extra 30% of the review to comply. I don't have statistics yet for how many would fail the DTAC because we're only just starting this. But again, we would imagine that not everybody would get through those minimum gateways. We're also offering to review against ISO self-certification and peer review now, including the new digital health ISO standard that will become even more important. And again, constantly we have, we're introducing a new AI component of our assessment. So if you're an innovation that has a component or an element of AI, we're assessing against that. And also, I think it was Guido that mentioned interoperability. So very, very important now, certainly in English health and social care providers, that applications, digital health solutions could be interoperable with existing health and care platforms. And again, we are assessing against the interoperability standards, and not everybody gets through. And the beauty of ORCA is that once you've been assessed for one nation, as you would expect, the requirements for another nation are very, very similar. So you only have to be assessed once, and we'll do the rest around piecing together the bits that are missing. But the most important thing is here, only 20% of those apps that we review either proactively or reactively make it through the minimum requirements.
Thank you, Ether. Yeah, I think we'll be closing here, Diane, because we're already 3 minutes late. And I want to give back the floor to Tino. Maybe Tino, the floor for the people who didn't see the results of the Mentimeter for the last two questions. Maybe you then re-show the results of the two last questions, if you don't mind, so that we have an idea, and comment it shortly.
Sure. From the beginning, I think it's very nice now how this wave shows that there are three averages, even it's 3.2, so there is a high diversity of opinion, no matter if it's for clinical care or for organization of services. So this was the first one, and nice to discuss why this is this way. In terms of low-hanging fruit, looks like PROMS is the most voted, followed by machine-generated monitoring data. And the last question regarding the situation, and we could add this additional bar to the left for not even start a discussion, but you can see a double average. So in some Asian countries implementing already and scaling up, while others are still in planning phase. So diversity is the reality. Going back to key messages, and thank you to all the panelists for your contributions. Some key messages to take away. One was clear in terms of the societal value as a must-have for a successful digital solution. Also the fact that interoperability and integrated data are becoming an essential ethical issue, and with this domain that Marcus was pointed out on security. The co-creation, as explained by actually both Yolanda and Guido's presentation, has to start from the start, involving all actors, and this is what will ensure that will provide value for the whole chain. And finally, the use case approaches as probably the most prevalent or more cost-effective approach in terms of validating needs, federating the community, and co-creating the service and the health data space. Seen from Yolanda's presentation in the case of diabetes, or multiple sclerosis in the case of Guido. For next session, just as an announcement, we are opening this new work stream on hybrid care. On 20th of May, we'll have one workshop on mainstreaming virtual care with new models of care. So we invite you to join us on 20th of May. And the second workshop on this stream on health data spaces and ecosystem will be focusing on hospitals and their challenges of going from electronic health records to data ecosystems to feed algorithms for clinical decision support systems. So also the date is to be confirmed yet, but it will be in June, and we will be very pleased if you can join us then. Thank you for your participation, to the speakers, Yolanda and Guido, for the front panelists, Belen, Javier, Heather, Eric, and Marcus, and all the ETL team for all the good work on the audience for the nice questions and the discussion. Thank you very much, and hope to see you soon.